When we talk about improving drug delivery, we're talking about really two things. One is improving absorption, so drugs that are not very well absorbed, low bioavailability getting absorbed, and the other one is by tuning the pharmacokinetics so that the drug becomes a long-acting drug. And I'm really going to be talking about those two scenarios today. It's a little bit about the long-acting concepts, a bit about injectables and about implants, and about novel mechanisms for oral delivery of drugs. And I'm going to be talking a little bit about variability, which is something you don't hear very much about when people discuss long-acting drugs. And drug interactions, are they the same? Are they different? Pharmacogenetics, will they be the same or will they be different? Okay. So why long-acting? I think most people have seen this sort of thing. Everybody here has been to a long-acting, several long-acting talks in the last year, and you hear all this reasons, pill fatigue, eliminating gut-based drug interactions, things like that. But the one group, time and again, that has been proposed for long-acting are the fragile populations, the people who find it difficult to adhere, to take treatment, and to turn up to clinics. And these are the people who are, in whom we're targeting long-acting therapies for, but there is a cost if they don't turn up for treatments and for their injections, and I'm not sure that we've thought through that issue completely yet, and maybe that's an area for discussion at the end. There is a difference in vernacular, so we talk about long-acting, generally in the context of injectables, whereas we talk about sustained release, modified release in the context of orals, although these things are now getting blurred with some of the new devices, particularly the orally administered devices that I'll show you about. There are many pharmacological considerations which I'm not going to cover today, but they are important. Things like the volume of injection, things like the amount of loading, drug loading, they're pharmaceutical issues. So you've got 1 ml of injection or 2 ml, which is about, which is quite a lot for someone to take. Can you load it up 50% with drug or 80% with drug? So there are issues around excipients and drug loading. There are issues around drug stability, the cold chain for rilpivirine. And formulation type issues. But ultimately it's potency. You don't want a long-acting, not very potent drug because that's a nightmare scenario. In fact, it's a glorious scenario if you happen to be a virologist looking for a job. I'm not going to talk very much about the existing long-acting formulations. The next two speakers will cover that. But as you know, cabotegravir and rilpivirine have been the most extensively investigated, both for treatment and for prophylaxis. We know about their metabolic pathways. We know about their PK, and we also know that. We also know that actually after a single dose of each drug, 1 year later, the drug is still detectable in some or most patients. Okay, and that's been shown for both cabotegravir and for rilpivirine in the latter in the MWRI-01 study. So other than cabotegravir and rilpivirine, what can we do? Well, we can change the solubility of the drug. And this is ironic because in the past, if your compound was poorly soluble, you went into the dustbin in drug development. And so now people are looking in the dustbin for exactly those kind of drugs with high potency but low solubility. So we take a drug like paliperidone for neuropsychiatric disorders, which is relatively insoluble, and we make it more insoluble by adding a palmitate on it, and it becomes a long-acting drug. Same with olanzapine. Triamcinolone, we change the salt to acetonide, and it becomes very insoluble, which is why those drug interactions that you see with ritonavir, cobicistat, and triamcinolone can go on for months because the triamcinolone is still releasing months later after that IM injection that everybody's forgotten about. Okay, and you get avascular necrosis and all that. We can change solubility, we can turn the drugs into prodrugs, which gets it absorbed and released in a much more controlled way. And so one of the ways we do it with nucleosides is to do this concept of protides. So we take a nucleoside and we turn it to a nucleotide. So we add a monophosphate group down here. We protect that masking, we mask that with an aryl group and we add an ester on it. And then it gets broken down. So it gets better absorbed, it gets delivered to tissue, high tissue concentrations, broken down by esterases, carboxyesterase, and cathepsin. And becomes its drug. And two of those drugs have made it to market. So sofosbuvir is a protide of GS331007, and Taf, of course, is a protide. There are two other interesting compounds here, which you probably cannot see. One is GS9131, which I won't talk about, but you've got an exciting session on drugs in the pipeline. And the other one is another GS drug, which is not an HIV drug, but has broad spectrum for RNA viruses, so being looked at for filoviruses, for coronaviruses. If your drug is not a nucleoside analog, you can add other things to it. So a myristoyl group, for example, which is also cleaved by esterases. So the Nebraska group, the Gendelman group have done this. They've attached dolutegravir and cabotegravir in myristoylated forms and then nanoformulated those forms. And two things come out of that. One is that you do change the release of it, okay? So it becomes long-acting drugs. And these are both IM formulations. But the second thing is that it seems to be taken up preferentially into immune cells. So here's something that we've not talked about with the long-acting, which is that you can actually preferentially target reservoirs. And we know from work done by Courtney Fletcher and Angela Kashuba and others that there are differences. So nucleosides get in quite well into GALT, into rectal tissue. We don't know very much about drugs in the lymphatics, but but a lot of nanoformulations now are being targeted to lymphatic uptake. Okay, we know that PIs get in pretty badly. And we know amongst the integrase inhibitors that elvitegravir concentrates in lymph node mononuclear cells at much higher levels than dolutegravir. So this is separate from genetic barrier to resistance and to potency and to receptor occupancy, but in terms of its characteristic, it does concentrate better. Does this translate into any evident advantage? Not yet. We see that with Taf and tenofovir. So with routine Taf, you're aware of the PBMC data, but there are some tissue differences as well between Taf and tenofovir. So if you look at inguinal lymph nodes, there's a 15-fold difference in concentration of tenofovir. If you look at spleen, if you look at bone marrow, again, these differences are evident. And then, of course, when every new drug is looked at, we start to look at whether where it concentrates. We're interested not just in reservoirs, but in drug sanctuaries, so testes, CNS tissue, particular interest. So you can adapt the drug. You can stick things onto the drug and make it change its behavior. You can change the size of the molecule as well. And nanotechnologies are. I'm not a nanotechnologist by any means, but Liverpool has a very active program led by Andrew Owen. And traditionally, we think about nanoformulations as just a solid drug nanoparticle, a particle that's just smaller in a nanoscale era. And you can do that simply by milling, simply by grinding the drug down in size. And to date, that has been the tried and tested way. So if you look at rilpivirine, cabotegravir, that's wet bead milling. So it's conventional, and nearly all of the licensed nanoformulations are prepared in this way. So the same, but smaller. There are advantages to doing bottom-up building of nanoformulations. So there are different ways of doing this. You can coat it in emulsions, but one of the ways that is being explored by Andrew and colleagues in Liverpool is this idea of nanoprecipitation. So you mix an aqueous organic layer, you put your active pharmaceutical ingredient in it, okay, and then you freeze dry it. So this is very scalable. We do it to coffee, and you can spray it on, okay. So and depending on the surfactants and excipients that you put in, you can control, and the physical conditions, you can control the size of the molecule, you can control the spread of the size, so that's polydispersity. And you can control the charge of the molecule. And those things make a huge difference as to whether it doesn't get in at all, concentrates preferentially in cells, or kills cells, okay? So there's been a big body of work that's perform this. But you can now tune this. You can also co-formulate ritonavir with lopinavir, for example, in the appropriate ratios. So this makes it a very controllable process. You can also stick drugs inside nanocarriers. So you can, and they come in all shapes and exciting sizes. And this goes beyond sustained release because some of these things also try and target drugs into cells. So for example, there are nanoconjugated folate drugs, atazanavir, ritonavir, again done by the Gendelman group, and trying preferentially concentrate inside macrophages. The received wisdom about nanoformulations is that it should have less variability. And this simply comes from the fact that if you give an IV drug, you abolish a lot of the inter-individual variability. So is that the case also with IM drugs? And the answer is no. And we've learned that from the injectable antipsychotics, for example. So paliperidone, olanzapine, you can see that the variability is higher even than oral variability with long-acting versions. And so it should not surprise us that that is also the case with rilpivirine and cabotegravir. Now, why is that so? If you give an injection, there's no adherence issues. A lot of the background noise should have gone. There's no diet issues either, okay? No. So if you look at the old data, so these are pretty old data of diazepam injected with a 3 centimeter versus a 4 centimeter needle, so a green needle versus the one size down, and you can see the diazepam levels are startlingly different. If you look at IM kefridine, injected in the deltoid, in the thigh muscles, or in the gluteus, you see a gender effect. You see a gender effect. Good golly. Thank you. I'm about to have a seizure here, right? Okay, so thank you. So you see a gender effect with high levels in males and females, and an opposite effect with dapsone. So actually, you can see opposing gender effects, and the one thing that seems to come out quite regularly in long-acting studies outside of HIV is that BMI and gender seem to be major determinants of drug variability and drug exposure. And the same thing has been seen in the HIV arena, both with cabotegravir and with rilpivirine. So you can see a gender effect of these are the absorption rate constants. For males, much higher than females for cabotegravir. For rilpivirine, the data are less clear. So in the SS8040 study that was presented by Marta Bofito and Akil Jackson, levels were higher in males and females. And that was similar to orally dosed rilpivirine that was described by the French in a population PK model. But in fact, the opposite was the case in the Pittsburgh study, MWRI-01. And this is the same formulation. It's the same formulation of drug, assayed in the same laboratory hours, showing two different sets of results in terms of gender, but still a clear gender effect. And so that's for plasma. If you look at rectal fluid, which is down here, or if you look at rectal tissue down here, between males and females, there's not much difference. And of course, levels in vaginal fluid, cervical vaginal fluid is much higher than in rectal fluid. Okay, so there does seem to be a difference and a lot of variability. Why is that so? Well, actually, injection variability is a big issue, and I think that we all know that. This is an interesting study that just illustrates the point. This is a study from India where they looked at 700 abdominal CTs, and they measured the gluteal fat, which is about 2 centimeters in men and 3 centimeters in women. And then they looked at people who'd had a recent or a past IM, supposedly injection for something else. And they found, for example, so this is how they measured the gluteal fat, and they found, for example, subcutaneous inflammation occurring from an injection that was supposed to be intramuscular. They found partially calcified granuloma of varying varieties. And in fact, if you remember the days of IM quinine for malaria, you find people going around still with golf balls subcutaneously from those injections. So the average length of a green needle, which is what we use, 20 to 22 gauge, is about 40 millimeters. If you use anything shorter than that, you haven't really got much of a chance of delivering an muscular injection. And even for a green needle, you have to actually go pretty much near into the hilt for that. So there's no space for gentleness when it comes to IM delivery. Interestingly, rilpivirine and cabotegravir were developed for subcut delivery, first of all, but in both cases, the studies were stopped because of an excess of injection site reactions. But the difference there is that you can, it's more reproducible, arguably, and you can self-administer at home. So maybe that's still something to aim for. What about drug interactions? So we know that this is as much as I can remember about the drug metabolism here. And so you've got first-pass metabolism at the gut and in the liver through the portal vein. And if you take a potent inducer, for example, rifampicin, you can induce gut PGP and cytochrome P450s, and you can have a big effect of first-pass metabolism. And of course, a long-acting injection has no effect on, bypasses that, okay? So you could reduce gut-based drug interactions. Of course, rifampicin also induces liver enzymes, and that will not be affected by long-acting, or will it? If you think about a drug, the amount of drug interaction from hepatic metabolism is only related to the amount that's being released. And all long-acting drugs have a slower rate of absorption, okay, from the depot. So the drug in the depot is not being interacted by rifampicin, it's how much is leaching out. And that's usually slower than the elimination rate, which is faster. So that does something that pharmacologists call flip-flop kinetics, which may modify your interaction potential. So I think we do need to restudy some drug interactions in the long-acting format that we've already looked at in the oral format. And some people in our group, Marco Siccardi, has done some modeling about what happens to cabotegravir. This is all in silico. There's not been so there's this in silico modeling showing that in fact there is still a significant drug interaction. Okay, so in my last 2 or 3 minutes, I'm just going to cover new delivery mechanisms. And I think top of the most exciting ones are these things called microneedles. So these are small patches. You can see that next to a big biro. And they can be solid, which are dissolving, or solid that deliver drugs, or else hollow. So there are various different forms of this. This has been looked at in terms of delivering insulin, in delivering vaccines, for example, and delivering drug. So in the insulin, they have these smart insulin patches that they've looked at where the release is controlled, is dependent on the glucose environment and the oxidation environment. And so I think you have to have a lot of trust. It's a little bit like a driverless car, really, and it's fine as long as it goes all right. But again, a very exciting development in terms of delivering drug transdermally. There are implants that you can put in. So these things here, which I know this looks like something you stuff down your trousers before you leave Colombia, but this is actually a thin film polymer device which is controllable, tunable, based on the polymers and the thickness of the film. Okay, so you can sustain release, and that's and then subdermal implants, and both of them have been tried in the context of Taf, okay? So these have been tried out in beagles. So no human studies, all animal data to date. I thought I'd throw this in because this came out very, very recently as a gastric-resident dosing for oral delivery. So again, polymers, 2 different sorts of polymers. One to control the structure of this this starfish-like structure, which can be loaded with different drugs or the same drugs to control release in different polymers, so that you can have a flat long-term release. And you swallow this thing, it gets dissolved, it springs open, and you can see that in this picture down here. And then delivers drugs slowly and can stay there for a long time. So again, this is another novel mechanism. I'm not going to talk about new drugs, but I'm going to flag up that there's a lot of interest in the Merck compound 8591 or EFDA, and you'll hear more about that on Friday. Likewise, GS9131, which is again a protide. And I'm going to finish on time with just 2 points about long-acting formulations. So clearly, you're going to hear about the efficacy, that's the most important thing, and effectiveness in these PrEP and treatment scenarios. We need to understand not just the acceptability, but how consistent is the PK? Does it matter? How reproducible is the injections? What about people who haven't got much muscle? Children, elderly people with a low BMI. What about pregnancy? If you stick something in for a year, you've got to have some idea of what happens in pregnancy, as we've seen in the last couple of weeks. And then a general issue about pharmacogenetics, which, and I'm not arguing that a lot of money should be thrown at giving people grants for pharmacogenetics, but relatively small differences from oral dosing, and we've seen many pharmacogenetic studies, could be amplified, depending on the mutation, could be amplified in a long-acting scenario. So I think we just need to have a bit of a thought about that, and then thought about how we manage that tail. And then a final thought about the reservoir. This is a new way of delivering old drugs, but are we actually at the ceiling of activity already for the old drugs? And is it so can we improve on the lymphoid penetration, the lymphatic penetration of these drugs? Will it make a difference? Or do we actually need new compounds? Thank you.